get blood transfusion therapy. The captain is the packed RBCs, gets the hemoglobin and oxygen carrying capsule. What is packed RBC? Those two effect. Can stop the significant bleeding. Thrombocytopenia, qualitative plastic defects. So in this situation, we'll get the transfusion in the platelets. Okay. Now the FIP or PCC. It calculates factor levels. That's one factor levels. Cirrhosis.
Cirrhosis. Cirrhosis. Cirrhosis.
Cirrhosis. Huh? Cirrhosis.
Cirrhosis. Cirrhosis.
Cirrhosis.
Cirrhosis.怎么了？Receptor 冷凝蛋白质。
爸爸，妈妈可惜我让我也不喜欢。
你就跟妈妈说呗。
我骑可是给妈咪。
Cruise 的。Okay. Trail. Free. Subject. Albumin， 白蛋白。Uncooked transfusion, transmission, transferring reaction, and overload into the chromatosis. The hypocalcemia. Citrate is okay. And the hypocalcemia. Obviously, this in all blood units. So first, what should we do? Okay, because stop bleeding, neutropenia, cognitive defects. Cognition factor levels. FP contains all coagulation factors and plasma proteins. Okay, so we can remember we talk about the anticoagulation reversal agent. So when we touch the warfarin, we always use vitamin K to get the slowly anticoagulation. But if you want to the rapidly reaction to stop the bleeding situation, we also use the vitamin K plus the FFP and PCC. Now the PCC generally contains factor 2, 7, 9, 10 as well as protein C and S. So that's the differences because the FFP contains all coagulation factors and plasma proteins. But PCC only have some limited, just such as the important clothing factors such as the 2, 7, 9, 10, and protein C and protein S. So cirrhosis immediately anticoagulation reservoir. So prior pre PITATE. Simple I know the zero domain. Fibronectin 骨架蛋白吗？ Physics. Parasynthesis. Cell post.穿刺后。
Alrighty, let's talk about blood transfusion therapy. This is a pretty simple topic once you know the underlying problems for which we're giving the different blood products. The different things that we can give are whole blood, packed red blood cells, isolated platelets, fresh frozen plasma, and cryoprecipitate. Let's understand this topic by filling out this table together. And let's get started with packed red blood cells. These are exactly what they sound like, just red blood cells. You could probably imagine what you would give them for, to replace people who have lost red blood cells. So now the next question is, who's lost red blood cells? What type of pathology would you see when you lose red blood cells? Well, that would be two things. First thing is, you could have a patient with acute hemorrhage or severe blood loss, someone who's bleeding out actively, or it could be someone who has a really, really severe anemia with, like, let's say a hemoglobin less than 7. And the effect of this is pretty much to increase the hemoglobin. By the way, when you increase the amount of red blood cells in the bloodstream, how does it impact oxygen saturation? Well, that's a trick question, because it doesn't impact oxygen saturation. But what it does impact is oxygen carrying capacity. And these are two different terms. Oxygen saturation refers to the ability of hemoglobin to bind oxygen more easily. And by just giving more red blood cells, you're not actually changing the ability of hemoglobin to bind oxygen. But oxygen carrying capacity is just a fancy way of saying that the blood as a whole can carry more oxygen. And that makes intuitive sense. By giving packed red blood cells to a patient, you're increasing the amount of red blood cells that's circulating through their bloodstream, which means that blood can carry more oxygen overall. So the effect of packed red blood cells is to increase the oxygen carrying capacity. Moving on to platelets, this is a similar concept to packed red blood cells. You really only give this when you need to replace what's missing. So what is it called when people are missing platelets, or they have a shortage of platelets? Good, that's called thrombocytopenia. And what are some pathologies that manifest with thrombocytopenia? That's right, ITP, TTP, HUS, heparin-induced thrombocytopenia, and so on. There's lots of them. And you can actually review this topic in full detail in the platelet and bleeding disorder videos in this very chapter. But the important distinction is that we really only use platelets as transfusion therapy when patients have thrombocytopenia, but then they also have significant bleeding. So you don't give this, for example, if the patient is stable and they just have purpura or petechiae, or they're just having mild epistaxis. But if they have significant bleeding, like they're bleeding into their joints, or they're having internal hemorrhage, and on top of that they have thrombocytopenia, then you would increase their platelets. And so the clinical use is to stop significant bleeding. And the effect of the platelets is, again, to increase the platelet count. Let's move on to fresh frozen plasma, or prothrombin complex concentrate. These are technically different packs of therapy, but they do the same thing. And it needs a little bit of explaining. FFP refers to fresh frozen plasma, and PCC refers to prothrombin complex concentrate. So these ultimately have the same goal, but they're made up differently. Fresh frozen plasma is just isolated plasma. It includes everything that your blood contains minus the red blood cells and the white blood cells. So pretty much everything that's in plasma is in fresh frozen plasma. Meanwhile, prothrombin complex concentrate is even more isolated, and it just contains factors 2, factor 7, factor 9, factor 10, and protein CNS. And by just saying 2, 7, 9, 10 protein CNS, hearing those factors in that order should ring a bell. And I'm going to ask you, where are these factors made in the body? That's right, they come from the liver. And they're made through a process called vitamin K-dependent gamma carboxylation, which happens in the liver. And if you want to review this topic, we actually have an entire video that covers vitamin K-dependent carboxylation in the physiology section of this very chapter. And there's actually a drug that we can give to inhibit vitamin K-dependent gamma carboxylation. Can you name what that drug is?
Warfarin.
That's right, warfarin. So the idea is that you give factors 2, 7, 9, and 10, protein CNS, or which is, prothrombin complex concentrate, or you give fresh frozen plasma if patients are lacking in those things. And so you can think of a few clinical scenarios in which patients are lacking in those things. One of them we just alluded to is if they're on warfarin and they accidentally overdosed and you need to quickly replace their factor levels, then you can give PCC or FFP. So that's one example. Another example that we can consider is if the patient has liver failure because of the very same reason. Because their liver is not working, they're not producing the factors that they need normally. There are other things that can cause it. For example, if someone accidentally ingests rat poison, and this is actually because rat poison is Coumadin, which is really just another word for warfarin. And you give these products, FFP and PCC, urgently or emergently in the setting of warfarin toxicity. But let me ask you, what can you give long-term for someone who has warfarin toxicity? That's right, you can give vitamin K. So again, just as a review, the effect of fresh frozen plasma and prothrombin complex concentrate is to replace our factors. And lastly, let's talk about what's called cryoprecipitate. This is just an isolated form of plasma that just contains fibrinogen, factor 8, factor 13, von Willebrand factor, and fibronectin. And these can be used for coagulation factor deficiencies, like, for example, hemophilia A, in which patients have a shortage of factor 8. Let's talk about a few side effects of blood transfusion. The first and most obvious is transfusion reactions. But the more high-yield ones that we can be asked about are hemochromatosis, and that's because if you overcorrect a patient's anemia, you can give them too much iron-containing red blood cells.
Maybe.
Another one that's pretty high-yield is hypocalcemia, and this is because the very chemical makeup of the transfusion products has the ability of chelating and binding calcium in the bloodstream. Another thing that can happen is hyperkalemia. Let's quickly wrap up the video by doing a quick flash quiz. Let's say you have a patient that presents with a petechial rash and constant nosebleeds. You check his platelet count and his platelets are in the 10,000s. How do you want to treat him? Well, in this patient, we're going to transfuse them with platelets. 10,000 platelets are very, very low. So you want to start this patient on platelet transfusion therapy to increase his platelet count. And at the same time, you want to explore your differential diagnosis for thrombocytopenia. And what would that differential diagnosis include? That's right. Immune thrombocytopenia, TTP-HUS, heparin-induced thrombocytopenia, DIC, so on and so forth. Well, that's really all we have for blood transfusion therapy. So if you like this video, then please be sure to leave a thumbs up. Thank you.
这是考试吗？
Warfarin overdose.
And donate to you.
Plasma, not in a second.
Donate to that. Sorry, but I don't have any money. My own money, stranger talking.
dosage. 来了。
爸爸吃饭了，到哪？吃饭。吃饭了啊。
嗯。没有。
妈妈。
好冷，好冷。拿了一条鱼吃了，快去。兜兜里看都是水，快穿鞋边儿的，后面都是水，你看踩了一脚，又踩一脚，多少钱
？Happy contains all coagulation factors and
今天马上要过年了，我可以去看一会儿电脑吗？
不可以。
为什么都是个考试的事儿啊？
你没全整了吗？
妈妈，为什么会这个？
generally contains factor. 啊，好了。 吃饭去喽。